Welcome to the EAU podcasts. In this episode, UROONCO Bladder Cancer Chief Editor Dr. Pradere talks to Dr. Shore on the results of the Phase 3 CREST trial. He presented at AUA 2025.
Dear friends, dear colleagues, it's a pleasure for me today to be at the AUA 2025 in Las Vegas. It's an honor for me to be with Dr. Neal Shore. Dr. Shore, you have presented today a really awaited randomized clinical trial, the CREST trial. Thank you very much for being with us today. I know it's a busy day. Can you tell us a bit about the main rationale behind the development of this trial?
So I think there's two things, and thank you very much for allowing me to speak with you and my colleagues at in EAU and UROONCO. So number one, BCG induction maintenance works very well. We've had great success with it, but it's not perfect. Still, our patients with high-risk NMIBC, high-grade TAG3, especially our CIS and our T1 patients, we see upwards of about a 40% recurrence progression rate. And those patients then get left with the gratification of being BCG unresponsive. Many times, historically, even today, the gold standard would be bladder removal, radical cystectomy. And then in certain places, US and other places, but not everywhere, there could be an opportunity for other therapies, such as intravesical chemotherapy, gemcitabine docetaxel, or in the U.S. we have nadofaragene firadenovec, which is a viral gene, adenoviral vector, which has an immunostimulation effect, given intravesically every 3 months. And then there's also recently the N803, which has been approved, which is concomitant BCG and an intravesical administration, and given induction, sometimes a second induction, and also following a maintenance schedule. And then, of course, based on the Keynote 57, the N803 was the QUILT trial, the Keynote 57, which led to the approval of pembrolizumab in BCG unresponsive CIS. And by the way, those are all CIS unresponsive patients. I think, and then of course, radical cystectomy. So what we know, that's one thing, is that we go into this cascade of sometimes very expensive to less expensive, but also therapies that have their own set of comorbidities, of course, and how they're dosed and how they're administered, inclusive of radical cystectomy. And even in the best of hands, radical cystectomy has a relatively significant morbidity and mortality effect, not to mention life-changing for the body. So the thought process of taking patients who have high-risk NMIBC, what could we do to augment their response to BCG? The gold standard. We know that BCG upregulates PD expression, and so we take a PD blocker, such as Sasanlimab, for urologists, and some medical oncologists will be very appealing because it's given subcutaneously. This is one of 4 trials, the CREST. There are 3 other trials. They're investigating essentially what I just described, the Merck 676, the Potomac, and the Albans trial, respectively, durvalumab, pembrolizumab, and atezolizumab. So there's obviously a lot of very bright people looking at preclinical model work and saying, how can we improve upon the current state of affairs, high-risk NMIBC, beyond induction maintenance BCG?
Yeah, I totally agree that anyway, we see that the immunotherapy and PD-L1 will be probably helping in BCG-naive patients as well. So, as you said, in the CREST trial, you were using Sasanlimab, which is a subcutaneous immunotherapy in combination with BCG. Can you just explain the design of the CREST trial?
Right, 3-arm trial, 355 patients in each arm, a stratification on CIS. We did some geographical stratification, but I think the CIS stratification is the more important one.
Yeah.
So we accrued completely during the pandemic, 14 countries, 140 sites, Europe, Asia, US, North America. And ultimately, our Arm A was Sasanlimab, subcutaneous PD blocker, given every 4 weeks for 25 weeks, in combination with 6 weeks of induction and then maintenance BCG for 2 years, a la the SWOG trial. Arm B was Sasanlimab, Q4 weeks for 25 administrations, and just an induction, no maintenance. And that was probably the most lofty goal. And then arm C, the control arm, was induction maintenance BCG.
With 2 years of BCG?
With 2 years of BCG.
Okay. And what are the results that you have presented today, the median follow-up, and the main take-home messages?
Main take-home message, the Kaplan-Meier curve comparing arm A with arm C, was that the hazard ratio was a 0.68 for the primary endpoint, event-free survival, which would have been persistence of disease, recurrence of disease, progression, and or death. And so a hazard ratio of 0.68 or 32% improvement for the combination Sasanlimab BCG induction maintenance, besting induction maintenance BCG arm C.
Yeah, and this was with a median follow-up or
3 years.
Of 3 years. And we see that the Kaplan-Meier curves are starting to really get different, especially after 24 months.
Yeah.
Do you have any explanation or why the effect is so long to be seen between the two arms?
Well, first of all, the adherence to BCG was very good in our study.
Yeah.
We probably
80% or
80%. And I think ultimately what that shows is probably much better than real world.
Disease.
That we see in the real world. People get BCG cycles fatigues and they don't come back. We get lost to follow up. So, BCG works well. So that was the comparator arm. As you say, the curves separated about 18 months. At 2 years, at 24 months, there's about a 5% delta and a little over a 7% delta at 3 years. And so that was remarkably reassuring, a 50% improvement across the board in terms of progression of disease. When we looked at the CIS patients who had a complete response, that was a separate dedicated KM curve. So just the 4.5% that had a complete response in both arms, at 3 years, 92% remained a complete responders in the combination, 67% in the monotherapy BCG arm.
For the CIS.
For CIS.
And that's really interesting. And I think that's one of the main questions that I have for you today. According to these results, do you see a specific population that will benefit for combination? Would you say this is a combination for everyone? How would you define the best patient, in your opinion, that would benefit from this combination treatment? Yeah,
no, that's a great question. It's being asked a lot. I'm still kind of thinking it through in my own mind. Yeah. Probably it's going to be best for, our prioritization. I'm not sure about the word best. That's always a bit subjective, isn't it? But prioritize the CIS patients and the T1s. Maybe less aggressive on the TAG3s, but of course, this is where shared decision-making comes into play. If patients have significant autoimmune disease issues or other comorbidities that would make me reluctant to give a checkpoint inhibitor and concerned about immune-related adverse events, which is a minority of patients, and let's assume that cost is not an issue, which it always is, regardless of where you are. But I think that I like the idea of combining novel mechanisms of action and optimizing the first line of therapy. We say, in a football playoff, your first shot is your best shot, right? You put your best player up there. So when patients' performance status is at its best, and these are like 80% ECOG zeros and 20% ones, you really want to give it your best shot at response.
Yeah, so I totally agree. And I think in these very high-risk patients especially, it's good to have your best shot. So we were talking about the duration of response. And I think it's an underestimated endpoint sometimes. And especially even in BCG-naive patients, I think when we talk to our patients, it's really important to explain what will be the benefit of this kind of combination. What is your feedback regarding duration of response?
I completely agree. Oftentimes we'll see these very high 3-month CRs, but really at the end of the day, what's happening at 6 months and certainly at 12 months and at 24 months? And how many patients then go on to other therapies? How many patients go on to remain cystectomy free? So I think that's, at the end of the day, that's a very, very practical, real world and very important metric.
Yeah, I think it's a good metrics to keep in mind when we discuss with a patient. Okay, thank you very much, Neal. Maybe one last question. There is a new problems with all these new drugs that are under development, especially in BCG naive field? Do you think that we will be able to convince our authorities, especially in Europe, to get a reimbursement and market access to these drugs?
Yeah, I mean, the bane of all of our existence as healthcare professionals is trying to get access for our patients. And it's very frustrating, regardless of the country, even if it's approved by your regulatory authorities, if you can't get it reimbursed for our patients. Nothing upsets me more than that. It's one of the reasons why I really enjoy having an active clinical trials program. I'm able to get my more indigent patients access to care. Breaks my heart when I can't give somebody care. I don't care what their passport is. They've got cancer. I want to treat it. And I think this is true about 99% of colleagues. This is why being a physician scientist, regardless of whether you're in Europe or Asia or Latin America or Africa or North America, we think about patients, not their passports. But for the health regulatory authorities, I understand it. They have to be cognizant of the health economic and budget impacts. But when you can start to do some additional analyses, which I really want to do, and I like doing this, is saying, look, we may have a more expensive combination recipe cocktail up front, but the downstream benefit is avoidance of additional therapies, additional hospitalization, progression, et cetera. There's an incredible cascade of other very expensive therapies. So spend the money up front early and get better responses is kind of a mantra that I like to follow.
Yeah, I think you nailed it. Thank you very much, Dr. Shore, for being with us on the UROONCO platform. It was really a pleasure. Congratulations again for this CREST trial, and hope to see you soon.
Thank you very much.
Thank you for listening to this episode of EAU Podcasts. To keep up to date with bladder cancer developments, visit our educational platform UROONCO Bladder Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.